thank you, the organizing committee, especially Dr. Lu and Dr. Luan, for inviting me to this wonderful conference. And also, I'm very pleased to meet my good friends here today. This morning, I'd like to talk about optimizing liver ablation, practical tips for enhanced efficacy and safety. As we all know, ablation is recognized one of the curative treatment options for early stage HCC in most treatment guidelines. To maximize the therapeutic efficacy, we need to do the novel technology, inclusion, precision, and AI-assist technology. However, we should remember basic must come first. Fundamental tips for achieving complete ablation and essential tips to avoid complication is important. These fundamental techniques are not thoroughly understood. The most novel advancement may fail to secure the long-term role of ablation as a curative option. 20 years ago, we tried to make the consensus on standardization in terminology. However, technical standardization is still a long way to go. Last year, Korean Liver Cancer Association published a document, Local Ablation Consensus, including patient selection, treatment imaging, and preparation and performing ablation and follow-up strategies. And also, Asian Society of Tumor Ablation recently published ablation guideline, including indication and imaging and techniques. You can check in this article. As we all know, we have too many weapons for local ablation therapy. Which one is best? This is a really long-standing question in every conference, but unfortunately, we don't have any clear answers. So I think it's time to move our question to how to use in a right way. As we all know, many experts expected microwave ablation would replace RFA from 20 years ago, but still RFA is still alive. Because at the moment, most studies fail to prove real benefit of survival of microwave ablation over radiofrequency ablation. Prospective randomized studies becoming challenging, especially when the therapeutic effects are similar, like microwave or RFA. The rate of local treatment application and overall survival varies significantly across institutions, which means we need standardization. Many factors influence treatment outcomes, making it all more important to interpret and apply with caution. And also we need greater consensus on procedural standards, as well as enriched training and dissemination of technology. And beyond just expanding the indication, we need to focus on optimization for existing local region treatment. As we all know, the devil is in the details. So it's time to dive into our past. Shall we dive in together? Successful local treatment can be defined as one that ensures the adequate ablative margin while minimizing both complication and mortality. So to balance between complete and safe ablation is really important, as we all know. Moving on, complete ablation. For complete ablation, we should consider 3 factors. First, careful selection. Second, precise planning. Third, accurate ablation. Careful selection. Achieving effective ablation begins with careful evaluation of whether the tumor meets criteria for optimal treatment. Please think in 3D beyond 2D, especially for tumor. 5 to 10 millimeter ablative margin in ablation zone is essential to minimize local recurrence because of microsatellite nodule surrounding the tumor. Selecting tumors that can be completely ablated with the available energy source is important. If the tumor is too large or has a non-distinct boundaries, achieving adequate ablative margin becomes challenging. If microvascular invasion on imaging is suspected, local ablation alone may not be sufficient for curative treatment. In such cases, multimodal approach incorporating resection or taste pair may be more appropriate. Again, careful selection of good candidate is critical. This is the first goal for successful ablation. Please carefully select the enemy that you can clearly kill with a single shooting. Moving on, precise planning. Meticulous pre-procedural planning is essential. We cannot build this kind of gorgeous building without the detailed planning. The selection of energy source, type of applicator, and optimal placement strategy must be carefully determined. Specifically decide all the details at the planning phase. Well-structured plan significantly improve treatment outcomes compared to unplanned reactive approach during the procedure. Please remember there are 2 intrinsic pitfalls of ablation. First, no device to provide spherical ablation volume. Second, our applicator path is not always parallel to the longest axis. Always consider whether accurate placement of any applicator can be possible along the largest axis of the index tumor. This is really key. If you are surely yes, you can use just a single electrode, either RF or microwave, depending on the largest diameter of the tumor. But our reality like this. So if you are not sure, please consider multiple applicator would be better to guarantee the circumferential ablative margin. We have to stop overlapping ablation with a single applicator when you cannot be sure of exact central puncture along the largest axis. No more overlapping ablation with single applicator. Moving on, accurate placement. Successful ablation depends on the accurate applicator positioning. Conspicuity always matter. So we need to consider enhance the conspicuity of tumor on ultrasound. First, Sony window optimization, position change, or use of artificial ascites or pleural fusion, and tumor conspicuity enhancement using the fusion and contrast enhanced ultrasound. Punctual placement is really critical. Take your time for really accurate placement. Moving on, safe ablation. For safe ablation, first we should know the broad spectrum of complication. Second, we need to prevent, and we need early detection and proper management to avoid mortality. There are so many spectrum of complication after ablation, from bleeding to seeding. And we have to prevent first and detect earlier as much as we can, and we have to properly manage. So, if so, how I do it? So this is my recipe, current recipe for routine procedure. As we all know, tumor size, location, and conspicuity is really important for successful ablation. Recently, I recognized that tumor exit is also very important. All factors are satisfied, I just do single microwave ablation. If any category, the answer is no, so at that time I use multiple RF electrode. So I prepared two cases. This is a single ablation using the microwave applicator. There is a conspicuous tumor with exit in safe location. In that case, I use a single applicator through the central core of the electrode, and then monitor using the fusion imaging software, so-called centrifugal ablation. They're pretty nice, just 4 or 5 minutes. There is no bleeding. Actually, almost no one, most minimally invasive approach. Pre-ablation MR and post-ablation CT, they consider the tissue contraction of microwave ablation quite successful. Second case is a 3 tumor with the inconspicuous and no exit tumor. That's why I used multiple RF electrode, so-called no-touch technique. The first electrode inserted at the third electrode, lateral superior margin of the tumor. Because the tumor was inconspicuous, start ablation from the posterior margin and anterior margin, finally lateral margin. I was quite sure oblating margin is enough. So-called centripetal hemangioma-like ablation. The second tumor is also, there is no exit because of this tumor is a high location. That means the posterior parenchyma is not enough. Also dangerous structure. That's why I don't use the single microwave ablation. Again, just 7 or 8 minutes, we can get the circumferential ablating margin. And finally, subcapsular tumor, sticky tumor. I just use the 2 electrodes and then ablate for 3 minutes. Really minimally invasive compared to laparoscopy approach. First ablation zone and third ablation zone. So ablation is well positioned in curative treatment option. So it is time to optimization. But compared to solo performance, I think, as you all know, orchestra is better. The harmony is a really key beyond optimization. I mean, the multidisciplinary approach is the really smart key to achieve the best result of our patient with HCC. This is our center study. You can see MVT cases shows better survival. So optimize liver ablation, and finally, do it together. Thank you very much.
Thank you so much. Excellent topics about ablation of the liver tumor. By the way, how many years?